This conference will now be recorded.
Okay.
And Rick, this is Mark Finn. I want to let you know that I will have to leave after about 30 to 40 minutes.
Okay. We'll try and get to you. Quick. Let me just ask you: is there anything that you wanted to raise today, Mark, for yourself?
I don't really need to raise anything. I can give you an update on my recent radiation treatment and so on. We can talk about that if there's time.
Okay. So let's just see. We've got one new guy, and so I'd like to try and take him first, but hopefully we can get to you before you leave. So,
Okay,
and if not, I'll try and interrupt so we can at least get an update from you.
Okay.
So here's who I see on the call: Jake, Dennis Correa, Paul Frieda, Peter Kafka, Rich Jackson, Les Shelderup, Mark Finn, Jim St. James, and Larry Fish. Did I get everybody? Guess so.
Yeah, Rich Jackson.
Yep.
Yep. All right. So, Jim, we run this call very much the same way as Peter runs his call. And so since you've never been on this call before, even though you've been on our calls, and if you're comfortable doing so, we'd ask you to introduce yourself and tell the guys a little bit about your situation, and then feel free to raise any issues that you might have around your chemotherapy.
Okay, great. Thanks for. All right, thank you everybody for inviting me. And I do have to leave in about a half hour. I've got some company coming, so I'll make it quick.
Okay.
I'm Jim St. James. I live on Maui. Peter's been really helping me out since November of last year. I was diagnosed with prostate cancer, 3+4 Gleason. I decided to do focal ablation in Florida, and did that in January of last year. Then when I did the focal ablation, they did a 3T MRI and they looked at a spot on my pelvic bone, which they also looked at here on Maui, but they didn't think was anything. But I did get it looked at in Florida, and then I ended up getting a biopsy, and it had metastasized into my pelvis. So after the ablation, I got radiation on that one spot, and did Lupron. And took a couple months off. I did some traveling, came back to Maui, and then went to Phoenix, and I actually did immune therapy for 30 days, low dose chemo and immune therapy. Everything looked really good. My PSA was low, nothing was happening, but I was having problems urinating. Went to the urologist, had it checked, and I had scar tissue on the bottom of my bladder. That I got reamed out, sort of like a semi-terp. And about a month after that, my PSA went from 1 to 80 in about a month and a half. I got into a trial, PET scan, the PSMA gallium-68 that Peter helped me get into in San Francisco. I went there in, I guess, when was it? February. And had the trial PET scan and showed that it had more metastases in various parts of my bones now, my spine, my hip, my breastplate, and they suggested I do chemo right away. So no, too many spots for radiation. So I came back to Maui and I did my first of 6 chemos 2 weeks ago. I'm having my second one next week. The chemo went okay. The Neulasta shot, from what I understand, makes your bones produce white blood cells. And that really gave me a lot of pain in my hands, my legs, everywhere, my back for about 4 days. It was really agony. But it did go away. And I've been doing pretty good the last few days, feeling almost normal again, actually, before my next chemo next Tuesday. So I guess my question is, any suggestions on on if it's the Neulasta that's giving me such pain. I thought about getting a green card instead of taking, Vicodin or Tylenol, which helped a little bit, but it didn't really do it. Maybe getting some oil, especially on my hands, to rub on my hands or whatnot for the next, round or two of chemo. And that's my story.
That's your story. So let me just ask you a couple of questions just to clarify. And Peter, would you do me a favor and send me Jim's email address so that I can add him to the list, please, when you get home? If Peter's still on. Peter, I don't know if Peter's still on. He may be. Yes, he is. Okay. So tell us a little bit about this.
No, I can't talk. Okay, go ahead. I got a phone call. Sorry.
Tell us a little bit about what you did in Phoenix. So, and when exactly? What was the time frame? You got the focal ablation back in the beginning of 18.
Yeah.
And then I'm assuming the pelvic mets and the spot radiation was pretty soon after that. Is that correct?
Yeah. Let's see my dates. Did the radiation in May of 2018. Okay. The focal ablation was done actually in January of 2018. Went on Lupron, then I had radiation in May. Then I had the immune therapy in June. Then I had my surgery on the TURP on the lower part of the bladder. That was in November.
So what was the, where did you do that in Phoenix? And what was this low dose chemo and immune therapy?
I went to, I'd researched a little bit about it. Forsyth does it. A number of doctors, U.S. Doctors do it. I went to Dean Silver in Phoenix. And I had, everything from curcumin to high dose vitamin C, quercetin. I'm trying to think. I only had 3 shots of low dose chemo, carboplatin and vinblastine. That the oncologist here on Maui knew about that. Knew about the low dose chemo, and he said, he said, ain't nothing like I'm going to be getting basically now. And what that did was actually, without taking Lupron, that kept everything down for a few months. I didn't take Lupron shot because my PSA was level, everything was looking good until I had that TURP surgery.
And what was the immune therapy, Jim?
Well, that was all infusions through IVs. Those are all IVs, the immune therapies. They also did, oxygenation of blood. That's part of the immune therapy stuff.
Okay. It's stuff I'm not that familiar with. It's fairly.
Well, I did the RG. Part of that is taking the RGCC test that goes to Greece, and it tells you what chemos work best for your situation. It tells you also if you have stem cell, cancer cells floating around.
Okay.
It tells you a lot of stuff, and then from that they take what's best from the RGCC blood sample, what would work the best, what's the most efficient.
Okay.
So that's how it works.
And did there seem to be any connection between did the doctors draw any connection between the timing of the TURP and the fact that your PSA suddenly shot up?
I talked to oncologists here. I talked to the oncologist in University of California, and they both shrugged their shoulders and said, "We don't know if that did it or didn't do it. We can't tell."
Right. Who did you see at UCSF?
Dr. What's it? Barn. Let me see. Get her name. Too many names. Too many things going on. I can tell you in a second. I'm gonna get my book open here. Baron, let's see, Borno, Dr. Hala Borno over there.
Mm-hmm. Yeah, I don't know her. I know a bunch of them, but I don't know her. I think I've heard her name anyway once before. But so the question now is, what would be best for you to do for the Neulasta, for the chemo, to avoid any uh, pain from the next dose of Neulasta? And has anybody else suffered issues with Neulasta? Dennis, you have pretty good experience with Neulasta. Have you had any issues from Neulasta shots?
Not really. We added that to my chemo, uh, getting the day after shot before they came up with the little module that goes on your arm.
Mm-hmm.
And my reasoning for getting it was because my white blood cells crashed, put me in the hospital for a week with multiple pulmonary embolisms and pneumonia. And
Mm-hmm.
I had to go on blood thinners and so forth, but they also added that new Neulasta. But I
Mm-hmm.
don't remember specifically that new Neulasta causing me any problem. I was just
Mm-hmm.
glad to be back and able to continue my chemo.
Right. Anyone else have any experience with Neulasta?
Hi guys, it's Larry. Can you hear me?
Yeah. Hi, Larry.
Hi, Larry.
Hey guys. Uh, I went through suffering with after my chemo, like 24 hours later or 30 or 48 hours later, I would go in for a new Neulasta shot because of the white blood cell count issue, and it always like led to really a discomfort and pain and feeling lousy. Um, recall back that uh, what happened was when I get chemo, I'd also get some prednisone. Uh, the method the
Dexamethasone.
dexamethasone, and that always helped the way I felt. And then I convinced the doctor to let me wean myself over the the chemo was coming every 3 weeks. The used to let me wean myself with 2 milligram dexamethasone tablets. So I would go from the whatever, maybe they gave me 20 with the chemo, or maybe more, and then I could take 4 the next day and 4 the next day, and then I had like a prescription for 2 milligrams, and I would take two for the next couple days, wean myself off sort of before, like after took about a week or so after the chemo, and then it helped me get rid of that problem of suffering so much from the Neulasta shot.
And what was the suffering, Larry? What was the discomfort that the
It was,
caused?
it was aching in the bones. I ached, and I had low dose fever, and I had tiredness and
Okay.
malaise. I didn't feel like doing anything. I laid around, and the death, the that the
So Larry, when you were taking chemo, were you not on prednisone all the time?
well, I would get prednisone with the chemo,
Right, but you weren't on prednisone
and I was
throughout.
on prednisone separately, and then I
Okay.
had like a couple of doctor would give me like 4 milligrams. Was it milligrams, I guess, and 4 milligrams for the next 2 days, and that
Right.
helped a little. But then I convinced him to give me prescription for two
Right.
milligrams,
So you can wheel.
and I would do it for about a week, and then I would
Right.
go clean for a week or two before the next chemo. I found that helped a little.
Hey Rick,
Okay. Because
my wife just reminded me that I did have pain from the Neulasta, and what they told me to use was Claritin.
right.
Yeah, they gave me Loratadine, which is, I guess, Claritin, to take
Yes,
one
it
day
is.
before. And I'm taking that. And they also gave me dexamethasone, the day the day prior and 2 days after to help. But I have been taking those, but I still had the severe bone pain.
Well, the clarity again. We are not docs, as you know. We can't give you medical advice, but I know plenty of people that have taken Claritin as needed because it's a fairly benign drug. So they take the loratadine, Claritin, if they're symptomatic. So you might want to check. The first thing I'd do is check if you can take it when you're symptomatic. If you've got pain, if you can take loratadine. Number one. Number two, there are some docs that have you on prednisone right the way through when you are on chemo, on low dose prednisone.
What is that? I
So,
don't know what that is. Prednisone
prednisone is a steroid. It is it's milder than dexamethasone. It's prescribed with some prostate cancer drugs like Zytiga. But if you've got significant pain and it might be an issue, then you might want to talk to your oncologist about whether you'd be a candidate for low dose prednisone. Is there anybody on the call that has taken prednisone right the way through their chemo, not just around the time that they're getting the infusion? It's usually dexamethasone they give you to do that. No, okay. But that's a definite suggestion, Jim, is to ask your doc about low dose prednisone right the way through if you're having those issues, and also the Claritin as needed.
Yeah.
Anybody else got any thoughts? Are you on one of those Neulasta patches on your arm? One of those little machines on your arm?
No, I went in and I got a shot after the day after.
Has anybody?
I was going to, Dennis stole my thunder. I was going to mention the Claritin also. But my understanding is that the most successful way to take it is several days before you get the Neulasta. Don't wait until you start having pain.
Yeah, they told me to start the day before, but maybe I should start more than the day before.
Well, yeah,
You
perhaps. And it doesn't work for everybody, unfortunately. The Claritin, in my knowledge, it does not work for everyone, but some people it helps significantly.
That's what they told me.
No, you don't want to wait till it starts. You want to take it up in advance, like you said, so maybe a couple of days prior.
Yeah, it sounds like a good idea.
Anybody got any other suggestions for this issue? What about anybody got any thoughts on the Neulasta gizmo on your arm versus getting Neulasta shots?
I think the big advantage is you don't have to go back to the doctor. You have to go back the next day to get the shot, but otherwise they give you the patch right there during the chemo. That's the advantage. At least that's what they advertise on TV.
Okay. Okay. So, again, I don't know if it doses differently or not. I mean, it may dose differently when you have the patch on your arm. Do you know anything about that, Dennis?
No, I don't. I think it's the same dosage, the same amount of stuff. Cost wise, I don't even know if there's any kind of a cost benefit to it.
Okay.
Yeah, I use that, like I said, I use that 12-hour Claritin is what I take. I
Okay.
started taking it for that, and I found that it also helped me where I was having this post-nasal drip that started up after my treatment and stuff. and that helped with that. And I'm still
Yeah,
taking it today. I just continue to take it every day.
Yeah,
yeah,
it's an antihistamine, so it would have that effect.
yeah,
Would have that
yeah,
benefit. Yeah.
yeah.
It is no
All
such.
right. Well, I want to check in quickly with Mark Finn if he's still with us. So, Jim, um, we will add you. Did you have any other questions you wanted to ask the guys?
No, I'm a newbie to the chemo, so taking it one day at a time.
So we have a lot of experience, as you can hear on this call with chemo. So as issues arise, don't hesitate to bring them up because a lot of times we got little tricks and ideas and solutions. You know, if you've got issue with your taste buds and other things like that, then we can maybe give you some ideas and some thoughts.
Well, great. I do have a question. Is this chemo? Can I even hope to get all the metastases killed by this chemo? I mean,
Okay.
that's the idea, right?
So this is docetaxel you're doing, is that correct?
Yeah.
Well, I think the answer to that question is complicated, and I don't know that we're going to have time before you have to go. And the bottom line is that there really isn't a treatment that nails the cancer completely. But each treatment that you take will manage the cancer for a good period of time. And how long you get is varies. Some men get months, some men get years. Some men do very well on chemo and not badly affected by it and go through many treatments, more than 6, because they tolerate it well. What is probably in your future at some point before too long is a second-line anti-androgen, such as Zytiga or Xtandi or Alida or something like that. And I'm assuming that you're back on Lupron at this point in time, correct?
Yeah, and Dex, what do you call it? Xgeva shots.
And Xgeva, yeah. So you're not going to get away, unfortunately. But Peter knows very well how to manage the Lupron better than most. And you can talk with him or you can talk with us here. But the chemo can. I mean, I have one guy I think of who did well on chemo for 2 or 3 years.
How much chemo? Just one go around, and then he was good for a while.
He was getting chemo every 3 weeks. I mean, we know guys that have done 40 sessions of chemo, but they tolerated it well.
Yeah.
So I don't think there's not a succinct answer, but we know it's a very good. What we do know is it probably extends your life longer than anything else.
Yeah. Okay, well, thanks. I don't want to take everybody's time up. Thank you, guys, and
Pleasure.
looking in.
That's a pleasure. Stay with us as long as you can.
Okay, we'll do.
We'll talk to you next week, hopefully, and you'll tell us how you're doing. I got your email. You'll be on the list.
Great.
And Mark, just before we come to you, somebody joined us on the telephone, and we haven't welcomed them yet. Who is that?
John Appler here. Sorry for joining late, Rick.
That's okay. John Appler. Hi. Okay. Okay, Mark, give us a quick update on your radiation.
Yeah, I just want to give an update because I had talked to you, Rick, about this, probably about a month or so ago. And I have stage 4 metastatic disease. I have, after going through my PET scan 18, it really nailed it down to 2 primary tumors, one on my pelvic bone, which is slightly over background, and one on my T6 on my spine. So my doctors recommended that not for palliative, not for any pain that I have, but that I consider getting radiation, which I decided to do. So I got high dose radiation. It was like basically three sessions, and the idea is to try to severely shrink, eliminate, whatever the case might be, my T6 tumor. So we won't know how that's going for a while. And this is sort of a kind of a, I think for a long time, any radiation was only done for pain management, wasn't done to actually try to improve your longevity. And so this is what we're trying to do with this. And it's turned out that, I finally had my PSA about a month later. I just had it yesterday. And my PSA has now dropped from like 6.5 to 2.5. My doctors tell me that you have to give it a little bit more time to see whether it will continue to drop or that's where I'm going to stabilize. We don't know yet. Just as far as looking at your options, this is an option if you have a limited number of tumors that might be able to go after. Now, if you have multiple tumors, many, then it's kind of like whack-a-mole, and how are you going to actually get after it? But my case, we did this, and we decided to only go after the T6 this time around because that was the most active piece. We'll come back, and if it turns out my pubic bone lesion tends to increase in size or become more active, then we might go after that at a later time. Okay, that's my update.
Well, thank you. So I remember going to an appointment with actually the guy that got the lot of chemo when he first started seeing Chuck Ryan at UCSF, and this has to be around 2010 or 2011.
Yep.
And they were using spot radiation other than palliative. I mean, they've been doing it for a while. The problem is that the success rate, as Chuck said at the time, is not very high. And I don't want to disillusion you, but and at the time he said, look, around 10% of people will have success. And as far as oligometastatic disease, I mean, it's been used in a curative fashion for quite a long time, but it isn't that successful. I was going to ask Peter, but I see his chair is empty. So
well, again,
I'm listening.
Oh, you're listening. So Peter, you've done a lot of research around using radiation for oligometastatic disease, haven't you?
Well, I did it yes, yeah. And it, so far it's effective for me, but it hadn't gone to my bones. It was still in my lymph nodes.
Right.
And I did proton beam, Mark.
Yeah.
They wanted to do SBRT with me, but I talked to my oncologist and did some research and did some other interviews, and I decided to go with proton.
Okay.
Where the Mets were and the collateral, minimizing the collateral damage and so forth.
Yeah,
I guess, Peter, my question's a little broader.
Proton therapy instead of SBRT seemed to be a better option for the spinal stuff.
My question's a little broader, which is, I mean, what did you find the literature said about using using radiation for oligometastatic disease in terms of it being successful in stemming the disease?
If you've got fewer spots, it can be effective. And, Dr. Kwan every year at PCRI, he highlights his successes, of course, so it's a little bit prejudiced, but he claims to have great success with knocking out a lot of oligometastatic disease. For how long, I don't know. He doesn't say stats, but with his slides, he shows you some pretty impressive data. So I think it's a good way to go.
Okay.
Yeah.
Okay.
We'll see.
We'll see. I mean, listen, we all hope it is, Mark. That's you've got all of our good vibes and prayers for you, and and we'll see. But I just think that, the expectations have to be relatively realistic. And what we do know is that the spot radiation does work well in a palliative fashion, but it works less well in a management fashion, shall we say?
Absolutely.
So, well, anybody want to talk to Mark at all about what he's done or the issues around the SBRT for oligometastasis? No, I guess not.
That's
You're
fine.
free to go. You can leave whenever you want.
Oh, I'll listen to everybody else's stories. It's always interesting.
Okay. All right. So let me run down the list and see who would like some time today, since we've addressed a couple of people who have some time crunches. So Jake, did you want to talk about anything today?
Not really, Rick. I was hoping Richard Wasserstug was going to be here. I wanted to ask a follow-up on the estradiol, but since he's not here, I'll hold it till the next time he shows up.
Yeah, I spoke to him yesterday, and I think starting very soon he has his dragon boat practice around now. So I don't know how often we'll see him on this call. It's because he's got his gym and he's got dragon boat practice. So, but if he's here, you can send him a note. Do you have his email?
No, I looked on the history and it didn't show an email. So.
All right, I'll put it in the chat window in a moment for you. Okay.
Yep. Thanks.
I have to sign out, so thank you, guys. This is St. James exiting.
Hey, Jim.
Okay. Take care.
Thank you.
Take care, Jim. Bye-bye. Okay, Dennis, anything for you today?
No, Rick, just here to listen in and participate where I can.
Okay, thank you. You're doing a great job. You're my go-to New Leicester man, as you figured.
Rick, that does. I do want to ask Dennis a question, if there's time.
There will be time. I will come back to you. Okay.
Yep.
Paul Frieda, anything for you?
No, I don't think so. Nothing tonight. Thanks.
Okay, but just to give everybody an update, Paul is out of the hospital after 4 days, and his pneumonia is finally walking away.
True.
Correct?
Thank goodness.
Good.
Viral pneumonia, no fun.
Good.
Glad to hear you're doing better.
Peter, anything for you today?
Not right now. No.
Okay. Rich Jackson, anything that you'd like to raise today?
All quiet on the Eastern Front.
Okay. Okay. Les Shelderup, anything for you?
Not today, thank you.
Okay. Not Jimson James, Larry Fish, anything you'd like to raise?
No, Rick, I'm good for this week. Thank you.
Okay. And John Appler, anything for you?
I'm good, Rick. Thanks a lot.
Oh my goodness, we got nobody who wants to talk today other than Jake, who wants to ask Dennis a question. I'm scrambling here. I've got to think what we're going to talk about. Rich just sent you Richard Wassersug's email. Okay.
Yeah, I saw that. Thank you, Rich.
Okay. Okay, Jake, why don't you ask Dennis? Make it a good question so that we can spend an hour and a half on it.
Jeez. Jeez, an hour and a half. I'm not sure if I'm good for that. Anyway, Dennis, I wanted to ask you when you were talking to Jim about when you were in the hospital because of the low white blood cell count, and the pulmonary issues. Was
Yeah.
that when you were on the Neulasta, or did they put you on the Neulasta after that?
No, that was the episode that caused them to put me on the new Lasta after.
Oh, okay. And it prevented it in the future for your other chemotherapy or chemo sessions. If the Neulasta prevented that issue again.
Well, that's not totally conclusive, but yeah, I did not have another episode, but they also cut back on my docetaxel dose that I was getting. I think it was about a 20%
Okay.
reduction.
Was that after your first session, or how many sessions were
I
you
think it
in
was
before you?
after 2 or 3, about halfway through.
Okay. I mean, that's very concerning. I mean, I know the chemo's in my future sooner or later. And that's very concerning. I don't want to spend time in a hospital or, have pulmonary blood clots or whatever. It's just kind of scary. But the Neulasta does prevent that. It did for you, at least.
Yeah, I'm bringing my executive secretary over here for
Yeah.
a bit. She can remind me of what I went through. When was it? In May, but I was about halfway through, right? Yeah, I was about halfway through. And
Hey,
I
Rick,
think
this is
the other
Mark Finn. I'm going to have to
recommendation,
go.
Okay, bye-bye, Mark. Thank you.
Thank you.
Jake, the other thing that I may have done that I shouldn't have is I let myself get into uh, situations where I may have been exposed to something and having a lower resistance. So again, I can't totally conclude that that did it, but my recommendation would be while you're going through the chemo is to avoid uh, those crowded situations like going to a movie theater or something like that where you're going to be in a crowd and you just don't know somebody's coughing or whatever. And I think that kind of what spurred my situation on. And I had it was multiple. It was pneumonia as well as the multiple pulmonary embolisms, both lungs. And that was the shocker. And that's what was giving me the excruciating pain every time I take a breath. And like somebody was sticking a spear through my chest. And after multiple doses of morphine for the pain, they came back and said, "Yeah, we're gonna immediately put you on a blood thinner." So I started getting injections, which I had to continue to do after I left the hospital. Uh, Abdominal injections of what did I get for blood thinner? Uh,
Warfarin?
no,
Warfarin?
no, they didn't like that because that had some complexities with your diet.
Mhm.
Ah,
Oh, I know the one um, you take it in your gut.
Lovenox.
Lovenox, right? It's an injection, right?
Yes, it's into kind of like where your love handles are.
Yes,
Around
exactly.
right around your waist there. You got to kind of
Yeah,
keep.
yeah,
It's
yeah,
Lovenox is the trade name for it.
yeah,
You took the generic.
yeah, 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 yeah.
Phil, you had this.
Yeah, enoxaparin, enoxaparin sodium injection.
Okay.
That's what it
So,
was.
Jake, what is generating this concern on your part right now?
Well, I mean, I've never had chemo, but with my PSA, rising, continuing to rise, I'm sure sooner or later I'm going to be on it. And,
Mhm.
I've always been scared of chemo anyway. But then when I hear Dennis tell stories about being in the hospital for a week, um, that makes me even more concerned. But
Mhm.
if the new Lassa does the trick, then I'm, then I'm, at least I have some hope. And as far as Dennis, as far as me avoiding crowds, I avoid people as much as I can. I can catch a cold over the telephone. Yeah, I mean that's good advice anyway when your resistance is low. But me personally, I don't go out that much. The only time I go out is when I go to the doctor, and I usually end up getting sick when I do go.
Yeah, and the other thing with the chemo, it's a little bit of a roller coaster ride. You're going to go through the first sessions and probably not have any feeling at all, like your just don't bother me. Then things gradually start to set in, like your taste buds start to change, and when you're feeling good, you're doing the exercise, and I kept kind of push myself with the exercise. So I think you get to a point where this thing is really wrecking your body, and you just got to say, okay, no exercise for a few days, whatever it's going to take till I start feeling better. And so that might have brought me down a little bit too.
Right.
But it's like
That's not bothering. It's not bothering Jake too much. The no exercise. Mary Lou, what did you want to say?
Oh, she left. She's not here.
Oh, I thought I heard her trying to say something.
No, she was trying to give me the name of the enoxaparin of the
Oh, okay.
blood thinner. Yeah.
Is that when you lost your hair, Dennis? When you had the chemo, or did you lose it before then?
No, that's when I had to get it. Was because of the pulmonary embolisms, the blood clots in my lungs. And that's when they did two things. They reduced my dose. They put me on the Neulasta and the blood thinners to slowly dissolve the blood clots, because you don't want those things going anywhere. And there was a point after, I forgot how many weeks I was on that blood thinner daily injection that my wife gave me ever so patiently, meticulously in the right places. And but they did do a blood test where they can tell. They use the term and said, "Well, your blood's not dirty anymore." In other words, the blood was not showing parts of the blood clots in it anymore, which that was, and then I was able to stop that.
Okay. I was just being a wise ass, so I asked you, did you lose your hair when you were taking the chemo, or had you lost it before then?
Oh, I lost my hair about 50 years ago.
Oh.
But then, I mean, after that, that was hair on my head. I did have hair on my chest, my legs, my arms, everywhere, which is about the only place I got it left now is a little bit of frizzy stuff on my arms and a little bit of around the back of my head and side of my head, where I have to just continue to clip that off.
Oh, okay.
That's my contribution to the hour and a half, Rick.
Okay. Well, this doesn't happen very often, and no one else has joined us. So we've got bags of time, an hour and 10 minutes, which we don't have to fill up. But there's a couple of things on my mind that I thought I might raise, and of course we got plenty of time for any issues that people feel aren't that important and don't usually have time to bring up, but they might have time, but they would have time today. So I'm going to mention a couple of things that might also make it into my next newsletter, into my next notice, which I had spotted recently. One of them is that PROSVAC does finally appear to be DOA. Now, the people that are involved in researching it say it isn't, and I'll explain why momentarily. But I saw today that a recent study on PROSVAC showed that there was absolutely no difference between the men who were placed who were given the Prospect injections and those who were not given the Prospect injections, with and without chemotherapy. Did anybody else happen to see that that in Medscape today?
No, I did not.
There was some, and it makes me a little sad because I remember really how excited Dominic was around Prospect. And he was so excited that he went out and he bought stock. And that stock did very well for a short period of time. And then after that, it didn't do so well. But the fact is that there was a lot of people that thought that Prospect had a very bright future, including, I think it was Pfizer, who bought the company in Norway or Finland or Iceland. I can't remember where they were based. Anybody remember? We need Len. Len would be right up on top of this. It was a vaccine drug that was supposed to stimulate your T cells. And in the phase 2 study, it did exceptionally well, got very good results. I can tell you how good, if you bear with me, because it was here. Where is it here? No, I don't. It's not jumping. Oh, I think. Just looking to the design. A phase 2 randomized placebo control failed to meet the primary endpoint. Okay, what was it then? There was something that did exceptionally well with this. This is it here. Yeah. The phase 3 international trial failed to corroborate results of a phase 2 trial, which showed almost a 10-month improvement in survival with the vaccine versus placebo. So, they had these great, they thought this was going to be the answer to prostate cancer. And unfortunately, they went on and they developed a phase 3 trial. And the phase 3 trial really did not produce particularly good results at all. So the phase 3 trial showed a median overall survival of 34.4 months with Prospect alone, 33.2 months for Prospect plus a GM-CSF compound, and 34.3 months for the placebo group. So it didn't really seem to make much difference what you did with the Prospect. So the question that came to my mind was, well, why did it do so well in the phase 2 trial? And one of the suggestions is that there are several new drugs that are being used for prostate cancer since the introduction of Prospect and the phase 2 trial, and possibly those drugs are making it less effective. But what they say at the end, I'm not sure. At the end of this article, and I put the article in the chat window for everybody, at the end of the article, they say the trial's failure to show a survival benefit does not represent an investigational death knell for the vaccine. They remain optimistic about the prospects for finding strategies to unlock the therapeutic potential of Prospect and cancer vaccines in general. In a recent review article, Gully and NCI College Jeffrey Schlom made a case for vaccines as an integral component of cancer immunotherapy, either by themselves or in combination with other approaches that target the immune system. So now they're saying, well, maybe we'll get some results out of PROSFAC if we match it with something. But so that's my little update on PROSFAC. Anybody have any ideas, thoughts?
Well, that is disappointing to me. So I had been looking forward to it myself, unfortunately. But I also saw that it had failed at phase 3. But I also saw that they were going to try combining it, as you said, with different compounds. They don't want to let it go quite yet. But maybe this Medscape article puts a kibosh on that too. I don't know. But it's very disappointing because it was a great idea to be able to go in, get a shot once or twice or whatever it was, and be done. You know, not like the Provenge, which is a real pain in the butt.
Right. So, anyone else have any thoughts on PROSFAC?
There's another one that has a similar name, and I can't remember what it is. It's similar to PROSFAC. It's very confusing. Yeah. You know what I'm talking about, Rick?
Yeah.
Well, the trial is called Prospect. Maybe that's what you're thinking of. The trial is called Prospect.
Spell it, Peter.
The phase 3 trial was Prospect, PECT. So
Prospect.
Confusing.
Yeah. No, there is another one. I think it is something that starts PROST.
It does, yes.
It does, doesn't it? What the hell's that called? Anybody? Well, John Appler, you're the one who's up on all these new drugs. Is this not ringing a bell with you?
Vaguely, Rick. I know you're saying I was looking for the manufacturer myself, but I just don't recall the specifics. I'm sorry.
Earn your keep, John. Earn your keep.
You're right.
Well, anyway, that's about. I think we've drug as much as we can out of PROSFAC right now for the time being. Now, the other article that I wanted to discuss, and this one ought to get you all your tongues wagging. And maybe what I'm going to do is just post the article first in the chat window, so those of you who are online can look at it. And this is something that showed up on MedPage today. So I just put it in there. And this showed up in MedPage today. And I don't know if anyone else saw it, but I thought it was a really good article. And I actually thought of a few people that I could actually direct it to. And the title of the article is Neuroticism, a Drag on Prostate Cancer Outcomes. And essentially what they say is that prostate cancer patients who were highly neurotic had significantly more adverse events following surgery than those who were less neurotic. And I don't.
I'm in big trouble then.
Well, you can speed read the article and tell us where it's wrong, Jake, because I put it in the chat window just now. But this sort of gets us into the whole discussion about managing your stress and your diet and exercise, because to the extent that you can reduce the outside pressures on your life, you do much better. And of course, this is not brain surgery. I mean, this probably belongs in my no shit Sherlock folder. But it's the reason why, you've heard me say so many times, if you're on a strict prostate cancer diet, have a blowout every so often. It's not going to hurt you that much. You're going to feel way better for it. And it'll lower your stress levels. When you see people eating a nice red juicy steak, I mean, it's okay to do it once in a while. And this is the sort of research that backs it up. Now, obviously, this is specific to surgery. But, I think of one particular fella who I've been working with since 2009, who has very, very, very low PSA. Even at surgery with 4+4 disease, his PSA was only 1.9. And the guy is a warrior. And, I'm sure that being so concerned doesn't help him at all. And his disease is progressing, but very, very slowly. I think his PSA is now up to about, after 10 years, it's slowly climbing to around 0.5 or 0.6. I can't remember without looking. But what do other people think about this?
Well, in the middle of this article, it gets into replacement in men with low-grade disease, and how they found that the reoccurrence rate drops pretty significantly. They found they weren't looking for this, but they found it in men that took testosterone replacement therapy, as opposed to those who didn't.
Yeah.
The three-year reoccurrence was much less, and that came up in quite a bit in my group yesterday, with the low and intermediate grade of guys that have just had robotic prostatectomies, and whether to boost testosterone so you're better and you're more vigorous. It seems to go against the thought, but for low-grade disease, it'd be the ticket.
Yeah,
I know.
I'm looking at that too, Peter. I don't think it has to do with the neuroticism thing. I think they have several articles kind of combined.
Oh, okay. Sorry.
But yeah, no, you're right. It's an interesting thing, and that's something that you talk about quite a bit on your call.
Yeah, I agree with the neuroticism thing that a lot of my work is with guys with all kinds of other cancers. I was just with a guy today who's going through he's got kidney disease and doing dialysis 3 days a week, and he's pretty bummed out. He doesn't. It's the first time I met him, but he's pretty low on the level of optimism, and how to get guys encouraged. Sometimes it's smart to take some medication, to take an antidepressant, how to get people engaged in life. And it makes me realize the value of these calls and how I see the real need for this kind of community to be expanded diseases, whether it be kidney cancer or mesothelioma or skin cancer. There's a lot of people, a lot of guys dealing with all kinds of stuff. they feel very much alone and isolated, and you can get pretty neurotic when you isolate yourself like that.
What other thoughts do some of you have on around this issue?
I agree. John Appler here. I agree totally with Peter. I think, reducing the fear level by these kind of groups, whatever comes next, as I said in my review of the organization, you're going to have guys who can talk you through it. And that's just invaluable in terms of lowering stress and letting your body fight the disease because it's not, dealing with stress issues. So I agree, Peter.
Yeah, I agree too. Excuse me. It's whether it's neuroticism or not, I don't know if that's the right term, but I mean just your general state of mind, your attitude. And I think that's what Peter was touching on, is your attitude about it. Your whether you're positive or negative, can have a big effect on how you respond.
Yesterday I was fortunate enough to attend a seminar. It's an annual seminar in memory of a dear and close friend of mine. Last year the speaker was B.J. Miller. And this year's speaker was a woman from Bellevue Hospital in New York, which is the oldest public hospital in the country. And she's an internist and a professor of medicine there. Her name is Danielle Offrey. I've put this in the chat window. And she writes in the New York Times, and she's published a bunch of books. And she just wrote a book called What Patients Say and What Doctors Hear. I made a mistake here. I'll put it in again in the chat window. What patients say and what doctors hear. And her whole issue is that she feels that a lot of patients don't feel they're properly heard by their doctor, and a lot of doctors don't give their patients time to speak. So there was a study done, she quoted this yesterday, that said on average, the doctor interrupts you after 9 seconds. And they surmise from what you've said in that 9 seconds as to how they should respond, and they don't allow you to give them enough information. And so she started doing a little test where she decided she said all of her colleagues thought she was crazy, but she did a test where she decided she was not going to interrupt her patients, and she just wanted to see how long they would speak for. And she said even the most long-winded, who she thought was talking for about half an hour, will only talk for 4 minutes. So, and she said, from a doctor's perspective, if you allow the patient to speak, she said it's money in the bank, because the patient feels so much better. They feel like they're being heard, and they don't feel like they've got to get everything out, and they don't feel so frustrated when they come in to see you next time. And she told a few stories around patients that she didn't give enough time to, and she didn't hear out, and some calamities that arose as a result of that. But I thought it was a very interesting discussion on some of these issues, these non-precise medical issues, whether it's your neuroticism, whether it's a lack of communication. Last Thursday night, and maybe I'll let, because we have the time, maybe I'll let Rich talk about this a little bit. We had a really good session with about 8 or 9 of us on the call about the language of cancer. And, you know, I'm sorry that more of you weren't on that call, because there are some people that are very offended by certain terms. There are some people who are not very offended, but somewhat offended, like Mr. Jackson, about certain terms. And there are some people who like those terms. So the bottom line is that the terms we use in everyday language in describing our cancer, they should be adapted to each person, that no single term really fits all. And there was a guy on that call, a young guy who has stage 4 colorectal cancer and has been through a heck of a lot. He's a professor at Wheaton College. And one of the things he said is, and because I wrote it down because it really struck me, he said, we should be able to describe ourselves as we best see comfortable. So if you don't like being called a survivor, then don't call yourself a survivor and don't let anybody else. Ask people not to call you a survivor. Use another term. Don't be shy to express it. Why? Because if it aggravates you, it increases your stress levels, it makes you more neurotic. You don't want to participate in calls, and you have every right not to be called that if it doesn't suit you. So, Mr. Jackson, what would you like to say about that?
Well, if we'd had this outstanding crew to assist us, it would have been considerably more entertaining and educational the other night. But, you know, we did manage to hold our own. But no, we were discussing the language of cancer. And again, as Rick mentioned, the word survivor, the battles that we fight with cancer, the war that's going on, how we're strong and, you know, we resist. And as Rick pointed out or mentioned about me, none of that bullshit applies to me. I was a survivor before I got cancer, before they told me. But as I mentioned, a survivor is someone who entered a situation in which they were not expected to survive the other side of it. Nobody anticipated that they would live. And as Jamie mentioned the other night, he deals with, works with FEMA and disaster psychology. So he would go in as some of the first people on the ground after a hurricane blew through or a tornado blew through. And these people just went through everything that you can think of, had their house destroyed around them, and they survived the tornado. Their neighbor died, but they survived. My point of view was, you know, concentration camps in World War II, the Bataan Death March, gulags and the Soviet Union. Those people are survivors. And I'm retired military, so the war metaphors, in war, our job was kill people and break things. And we're very good at it. But somebody wins and somebody loses. So if I'm in a war with cancer, eventually I die. By default, the cancer won because it's still around. So I'm not in a war. I'm not in a battle. I'm not stronger than the cancer is, because eventually, again, I die, and that means the cancer was stronger than I was. It outlasted me. One of Howard Walensky is a writer for MedPages Today, and he was on the call as well. And he's in active surveillance. Has been for what, 10 years or so, Rick, I think?
Yeah, a long time, yeah.
Long time. More biopsies than he cares to think about. And one of the men that he knows is also on active surveillance, and they tell everybody to listen. He's just that this other guy's a survivor. I'm a survivor. I'm a cancer survivor. And Howard looks at him and says, "You're on drugs. What have you done? You had 3 PSA tests and 2 biopsies." Not exactly what Howard would consider survivor material, but the gentleman is comfortable, and that's the term he prefers. So what does everybody think about some of these terms and how they apply to each of us individually? Peter, you look deep in thought.
Yeah, interesting conversation. Yeah. I don't particularly use the word survivor myself. I don't like referring to myself that way or others. There's a little bit of a sympathy play in my mind that's going on with that term. Yeah. And so no, I was playing around with the word survivalist, and wondering if we were survivalists, which is a little more macho maybe. I don't know. I don't know whether it works for me or not.
Okay. Well, Dennis, what do you think about it?
I just got to get myself unmuted here. None of those terms seem to cause me any distress personally. But I guess, if you had to describe it, and I don't know if there's a word for it, but what I would say is I'm living with cancer, and it's about finding the best way to live with it.
Mm-hmm.
That's kind of how I face it and how I look at it.
Mm-hmm.
And there's
Mm-hmm.
always, there's always that balance, but I can't find one word that would express that feeling.
Mm-hmm. Mm-hmm. How about Larry Fish? This sounds like a topic that you might have some ideas on, Mr. Fish.
Well, I guess I have ideas, but I don't know. It's sort of like I don't care if somebody wants to call themselves a cancer survivor or tell me I'm surviving. I don't think surviving cancer survivor is the right term. I think it's like I think it's a disease that's probably going to kill me eventually. Maybe we'll be really lucky, and we're going to be the ones who stay alive long enough for them to come up with kind of a durable maintenance solution. So I would call myself a cancer fighter. I would say I'm fighting because I come to the group every week. I try to stay informed. I discuss options with my doctor. I try to do things to help, like exercise or take statins or take metformin or hopefully deal with my diet someday. And so I think I'm fighting. I'm fighting to stay alive. But survivor, I don't even know. I mean, I work with someone who had breast cancer, returned 11 years later out of surprise. I don't know who survives cancer. It's always a risk.
Mm-hmm. So, Richard, what do you think about? How do you feel about people that feel comfortable in terms of using some of these more aggressive war terms because they're taking like Larry, taking very active acts on a daily basis to ward off the disease.
Well, no, I don't object to anyone's use of a term. I object to someone assigning the term that I don't agree with. If in certain situations I've had to adjust my mindset to get something accomplished, and dealing with cancer or dealing with any major issue or any disaster is you're in a similar situation that the neurotic person worries about every single thing, where someone that's more likely to make it through the other side worries about fewer things, but they fix their mind on, this is what I can do, this is what I can control. And using those terms that you find comfortable, that decreases stress, that increases the likelihood you're actually going to pursue what you feel is necessary, and then follow through and accomplish the mission. So back to the car commercial, your mileage may vary.
In a similar way of thinking, I always have this question about, like, well, how often do you think about or worry about or concerned about your cancer disease? How does it, impact your life on a daily basis? Is it something just that's always in the back of your mind, or is it something that, comes to you every day in the shower or in bed, or like how much of your active life can you go on with without having this impact your life? To what extent do you get obsessed with it? How do you try to avoid being obsessed about the disease when it's doing you no that obsession may be doing you no benefit?
Good question. Who wouldn't? How about Paul Frieda? We haven't heard from you. What would it does it obsess you? Are you with us, Mr. Frieda? I guess not. Who else like to take it? Les, how about you? We're putting them all to sleep here.
Yeah. Well, I don't obsess about this stuff, but I probably think about it more than most because I use it as a connection. I mean, it's led me to men that I never would have met otherwise, who are at very vulnerable places in their lives and in need of a friend. And it's had some remarkable experiences with it. And there's a trusting connection and bond that's shared just because I've gone through some stuff, and not maybe as much as they're going through, but it cements us. So I use it. I'm really in some ways I'm proud of the fact that I've managing the cancer the way I am, and using it as a connection tool rather than something that's clubbed me over the head. So it's debilitating me.
Anyone else? Well, one thing we are going to do is we're going to have a plenary on this issue around the language of cancer. And there were a lot of terms. I mean, Richard Wassersuch, who has actually written on this and has been published in the New York Times and the Guardian and other newspapers, says to me that he counts maybe a dozen or more terms. One of the phrases that we spoke quite a bit about last week was cure, because people like to, they want to be optimistic enough to think in terms of cure. That was like the question that Jim St. James asked me at the beginning. How good is this chemo going to be? And, will it get rid of the disease? Well, cure is a tough word when it comes to advanced prostate cancer. A lot of advanced cancers, not just prostate cancer. We talked about durable remission, and Jamie Ayton, who was on that call, said, that's a great expression. I never heard that expression before. I'm going to use that expression. So we've decided to come back and revisit this on a wider basis with a panel of 3 or 4 people from different cancers, and have a plenary on July the 29th, I think it is, the 5th Monday in July. And so if anything comes up, you think of anything between now and then, bookmark it and let me know, and we'll return to discuss it at that point. So I won't draw the call out longer. There's no reason why we shouldn't finish early for a change. It's a pleasure for me to do that. Is there anything that anyone on the call would like to bring up regarding pretty much anything before we finish? Mr. Frieda, you turned your mic on. Are you with us?
Yeah, I'm here.
No, we just called on you, but you walked away. We wanted to know what you thought about all this language around cancer and neuroticism, etc.
Thought about what?
The discussion we've been having for the last 10, 15 minutes.
Yeah, I doze in and out, and I missed the last 5 minutes.
Okay. All right. Well, not to worry. Not to worry. Okay. Is there anything you wanted to raise?
Me, Paul?
Yes, you, Paul.
Yeah. I'm wondering, is there when you're on Lupron and you then go off it for either a holiday or for whatever reason, does the PSA go up ever before the testosterone? In other words, your testosterone is below 10, your PSA is undetectable, and what you would expect is that you're not taking Lupron, so eventually the testosterone starts to come back, and then that feeds the cancer, and then the PSA starts to go up. I'm wondering, is that always the case, or is that or not?
Well, going back, how many years? About 8 or 9 years, I did do some research into the patterns of how PSA came back. And there was very, very little that was written on it. There's a fair amount that's written on how quickly your testosterone comes back, but there's very little written on how your PSA comes back. And I don't remember seeing anything written on how your PSA and your testosterone comes back. Has anybody got any input on that?
I'd have to look at my data. I don't know. I don't know how many men get their testosterone checked on a regular basis with their blood work, with their PSA. Probably not many. I mean, I'm doing it now, but not many do that.
Yeah, I don't think we have a good answer for you, Paul.
Okay, I just wondered and thought maybe someone knew something like that. You would expect normally that if you're not taking the Lupron, that the testosterone eventually comes back, and then the PSA eventually starts to rise. What the delays are and the times are, can vary depending on the person and that sort of thing. But so anyway, that's my situation right now. I do blood work about every 6 or 8 weeks, and one day there's going to be something that's that's a different than less than 10 for testosterone and undetectable for PSA. And I'm hoping it takes a long time. That's all.
So, are you going on a holiday? I can't remember.
Yeah, I haven't had a Lupron shot now for about 7 or 8 months.
And your testosterone is still
Testosterone is below 10 and PSA is undetectable as of
okay.
I guess 3 weeks ago, something like that.
Well, that's and how are you feeling? Do you feel a difference?
No, I can't say that I feel a lot better or stronger or anything like that. I mean, I feel fine, but but I can't say that I notice a difference. And there's no indication that the testosterone, that the testosterone, if I didn't check the testosterone, I would have no idea that it's not because, I just, I feel like like I have for the last several years. So.
Peter, how long did it take for you to see testosterone the first time?
I'd have to go back to my records. I've got them all, but I'd have to do some, pull them out of my files and take a look at it. I can't really answer that right away. All I know is I hope I get something before 7 months showing up. I don't know. That seems. Were you on, Paul? Were you on ADT for a long time before this holiday?
3 years.
Okay. Okay. My last venture was only a year. I was on second line, so I'm hoping it comes before too.
Which one second line? Zytiga?
Zytiga. I've been off now for 3 months.
Okay.
So a question came up in the group yesterday, and I did a little bit of research, and I couldn't find much on it. One of the guys is seeing a naturopath. He just had surgery, robotic surgery, very recently, and the naturopath said he had low testosterone that showed up in a urine test, and I'd never heard of that. I mean, I know they test testosterone with blood tests, and I researched it, and I could not find anything about a urine test. I don't know. I never heard of it before. So it was a mystery to me. It sounds like a naturopathic game to me, but I don't know.
Mm-hmm. Yeah.
I have not heard of that. And when did you get your last shot? Your last Lupron shot in October?
Talking about me, Paul?
Yes.
Yeah, my last shot was, I believe it was August.
August. Okay. So it ran out in around November time, huh?
Yeah. Yeah, I didn't do the November shot.
Okay.
So what is that? That's September, October, November, December, January, February, March. So that's 7 months. 7 months.
Yeah. So you've been off for about 3 to 4 months. I mean, I know in my own case, I didn't see anything after 3 months. It took about 6 or 7 months before I saw something. Because remember,
okay.
I mean, you had a shot in August, so that shot is in your system and well into November, if not December. So you're not really you've only been out of it for about 3 months, and it takes a while for your body to wake up.
Okay, I see how you're counting differently than me, but okay, all right, yeah.
Well, you can't count
what's the half-life of Lupron?
Oh, it's long. It's pretty long. I don't know. Peter, do you know the half-life?
I don't know. It seems to take a long time.
It's very long. I don't have.
Let me ask Google.
You are that's.
What is the half-life of Lupron?
Approximately 3 hours. According to
Google just said it's 3 hours.
Yes, we heard.
That can't be right. I hope
Yeah, don't believe everything you hear on Google.
I guess not. I'm like, oh my God, yeah.
That might be the time from the time you mix it to how long it's good for before they inject it. You know what I mean?
Yeah.
Treatment.
Well,
If
Paul,
you go,
Paul, you had a shot in August that was good for 4 months.
Yeah, well, I get a shot every 3 months.
Every 3 months. So that shot is going to last for 3 months as a minimum at
right.
Right. No, no, no. I
100%
know that for
strength.
sure. Yeah, and I can't understand why Google would come back with 3 hours, but yeah, you would expect that you've got at least 25% left after 3 months.
No, it's 100% effective at 3 months, because if it wasn't, then they would want to give you, it would either be longer. So it's,
So you think the half-life must be 6 or 8 months or something like that, or more?
well, your body, what they did was they flooded your body with a chemical that shut down the pituitary gland. And depending on how long it's been shut down, what is a factor in how long it's going to take to reactivate once the chemical gets out of your body sufficiently that the pituitary notices that, hey, I need to do something.
Right.
So figure you've got at least 3 months of the shot itself, fudge it for another month or two, just, kind of the eddy currents as it dies out and your body finishes disposing.
Right.
Then the pituitary has to notice, like, holy crap, it's a low level alarm. I need to do something
Well,
and
there's another.
turn back on.
Okay, yeah. There's another factor here. And remember, there's a 1 month Lupron shot and there's a 3 month Lupron shot. So, and they're
And a
both
4 month and
Luprons.
a 6 month.
And they're
Maybe
different.
it's the amount that they give you, I guess, is
They're different amounts.
that all? Okay.
22.5, I think, is the 1 month.
I think
Well,
that's
it's
the
a
three.
3 months.
3 months. 22.5 is 3 months. 7.5 is 1.
Okay.
Yeah, okay,
There's
there you go.
also a 4 month and a 6 month version.
Okay, yeah, okay.
But they just increase the dosage. They don't, the chemicals, the mix is still the same.
Right. But
So
something else you need to keep in mind is that a lot of it depends on your age. The length of time you've been on the Lupron and your age can affect how quickly you respond. And some people never recover. The testosterone anyway. Some people never recover it, even after several years.
Is that right? Wow.
Yeah. But I mean, in your case, Paul, you're in good shape actually, because your testosterone is low, your PSA is staying low, so that's a good sign because it means that your cancer's not moving along.
Oh, for sure. Yeah, absolutely.
So
But
I'd be saying,
the day's going to come when I get my blood work and I'm going to start to get nervous because the numbers are going to start to rise. I'm just hoping that it takes a long time.
well, that's where it depends on your age and how long you've been on it. And like I said, some people don't recover at all. Some people it takes longer. And it depends on the severity of your disease. I tried intermittent several years ago, probably about 5 years now, and it only took about 4 months for my PSA and testosterone to start rising very rapidly. But that's because I had aggressive cancer. So
Wow.
it depends on the person.
How many years ago was that?
About 5.
So you've survived 5 years after the failure of the Lupron.
No. I stopped taking. I tried the intermittent thing that Maha Hussein had written about. I talked my doctor into trying me with the intermittent Lupron shots, and my doctor said, no, that won't work with you. And she was right, it didn't. But I said, well, let's try it. But
Okay, so when it came back, you jumped back on the Lupron. Is that right?
Yeah. Correct.
Okay.
So what I'm saying is, everybody's different. Everybody's going to respond differently. How long were you on the Lupron? Did you say?
I was on the Lupron for 3 years.
And how old are you?
I'm going to be 72 in a couple of weeks.
Well, so maybe you may not respond that quick. 3 years is a long time. Number one, 72, you're getting up there in age, so it may not respond that quickly.
Uh-huh.
What was
Yeah.
your baseline? What was your baseline testosterone before you got sick? Was it pretty high? Did you have pretty high testosterone, or was it?
No, I don't think it was much more than 300, 250 to
Okay.
300 or something like that.
Yeah, that's another factor.
Yeah.
It seems
So-
like this. It seems like it's kind of complex when I look up the metabolism of Lupron. I mean, it does say following administration of Lupron has to take for deposit suspension, blah blah blah. Less than 5% of the dose was recovered in the urine. That metabolism of a 1 milligram bolus of Lupronide. The mean systemic clearance was 7.6 LH with a terminal elimination half-life of approximately 3 hours, which doesn't make sense actually to us, right? They give you 3 and 6, 1 month or 3 month or 6 month. If the half-life is 3 hours, there's nothing left in a few days.
It's a
Yeah, that
depot
It wouldn't
shot.
matter how much they gave you. It doesn't make sense. There must be some kind of other
Yeah, 3 hours does not
engine that
make
it
sense.
goes in.
Right. Listen to what Rich Jackson just said. Go ahead, Rich.
It's a depot shot.
Right.
The Lupron is actually encapsulated in basically a dissolving semi-solid chemical shell. As your body, so they put in for 3 months, they give you 22.5 of Lupron, but it is encased in basically a P or a biologically dissolvable shell. As time goes by, your body starts dissolving the shell, which releases more Lupron into the body, into the bloodstream.
Yeah, the depot makes sense.
So they're not giving you 22.5 right now. It's designed so that it's a time release capsule.
Right, it probably has different shells of different thicknesses or different sizes. Multiple.
They
Because
just
it's
make
probably
it bigger.
pretty complex.
They just make it bigger. But it's a 2-part or a 3-part mix that they have to basically create in the doctor's office and then inject it in. Basically, it goes in and solidifies, and then the time release starts.
So if you go Paul to PubMed, I just put a link in the chat window. If you go to PubMed and you search for testosterone recovery after LHRH in prostate cancer, there are 43 articles that come up, and they address how quickly the testosterone will come back. And some of them, I think, some of those studies are age sensitized, and some of them are based on the aggressiveness of your disease or the stage at which you got the Lupron, et cetera, et cetera. But you can plow through those articles, look at the ones that look most appropriate, and you can make a book report for the next session. How about that?
Sounds good.
Who are you talking to?
You.
Oh, you're talking to me. You said PubMed?
Refrigerator, please.
There's a link in the chat window, Paul.
Yeah, I'm looking for it. I can't find it.
Right at the bottom. Right at the bottom of the chat window. There's a link there to 45 articles.
I know we went in early, but one concern I have is, so how effective and accurate are these dissolving depot shells, whatever you call them? Like what kind of Lupron are you getting every day for the next 3 months or 6 months? How accurate is it in giving a steady dose? Has anybody seen anything about the levels? Are the levels pretty accurate? Or they rise and fall? Does it make a difference? I don't know how much they did on research they've done and all that.
They've been given a shot for a lot of years, and I'm sure they've gotten pretty good at it.
Yeah. I requested my doctor to give me the Lupron shot, the 3-month shot every 11 weeks. She said there's a 10-day variance you can get it a little earlier, because I didn't really want to take a chance that in the last week or two there wasn't any Lupron left. So she said she would do that, and that's why I arranged to get it every 11 weeks or so.
Well, the other side of that coin is that I always understood that it actually goes on for longer. It goes on a little bit over. So a 90-day shot is probably good for at least 100 days, if not more.
Right.
That was always my understanding. But have they done the studies? Probably. I mean, you could call AbbVie, you could call their helpline and ask them to send you the studies, because they're the ones that are going to have it. The people that make Abbott, who make Lupron, or if you're on Zoladex or Eligard, whoever makes that, they're gonna have the results for their drug. But my guess is they're pretty well regulated on that, because this is an FDA approved drug, so it's got to do what it says it does.
Yeah,
Yeah, I would agree
I
with
agree
that.
with that. I remember reading somewhere that the 1, 3, 6 or 1, 3, 4 or 6 month shots a lot of times are given based on convenience to the patient and to the
Yeah,
doctor. You know,
yeah,
because it is a
yeah.
shot. So some people don't like to go to the doctor more than once every 3 months. Some people don't like to go more than 6 months. And I think that's the big thing. As Rich said, they've been around for a long time, so they've got the dosages down pretty well pat, and they know how well your body absorbs the bolus or the depot over time. So I don't think that's a concern.
So while we're on the subject, Rick, I can't remember what the rationale is, but I mean, right now we're talking about hormone sensitive, but when you're resistant, why do they keep giving you Lupron shots? When you got a PSA, why do they still insist that you stay on Lupron?
Because they feel that the additional testosterone that would be generated if you were not on Lupron could in fact aggravate the disease. So in other words, your disease, if you're castrate resistant, is rising in the absence of testosterone. But if we gave it testosterone, it would rise even faster. So we want to keep.
It goes back to that language thing we were talking about earlier. When people say that Lupron stopped working, that's not true. Like Rick says, it continues to work. It does have a suppressive effect. It just is not as working as effectively as it once was.
Or wouldn't you think
No,
that?
no. Hold on a minute, Larry. Let me just. The Lupron's working fine. The Lupron's doing exactly what it always did. It's stopping you producing testosterone. But the cancer is responding differently.
It's
The
making its
cancer,
own testosterone, right? It's making its own food.
right? The testosterone is finding a way to exist and survive in the absence of testosterone. And if you stopped taking the LHRH shot and you had lots of testosterone in your body, the fear is that it would grow even quicker, because then it would have not only is it finding its own testosterone, it has plenty of natural testosterone that's in the body. Now, what happens for somebody then like Al Fat, who's on monotherapy Elida? So there are a whole series of drugs like Xtandi and Elida and darolutamide that are androgen, that act on the androgen receptors, and they block the androgen receptors from feeding on the testosterone. And the theory there is, it doesn't matter how much testosterone you got in your body, if the cancer cannot feed on it because its receptors are all blocked up, doesn't matter whether you're on an LHRH drug or you're not on an LHRH drug. And so that's why the monotherapy apalutamide may work for some men. Am I making sense to you, Peter? You look puzzled.
Yes. No. It's making total sense.
Okay.
All right. So wouldn't you also think that although the cancer is mutating in such a way that it can find a way around the effectiveness of the Lupron shot, that it's not 100% of the cells, that it's mutating to some extent, but some of the cells are also still being affected by Lupron? And why would you want to stop Lupron and take a chance that those cells could proliferate as well? That maybe it became 40, 80% effective and 70% effective and 60% effective and 50, and that's why you're adding Zytiga or something to Lupron in general. Although you may try to just go like apalutamide or something with a monotherapy, that's still a very experimental, and my doctor felt there wasn't any research showing that was necessarily an effective method, and that you would stay on the Lupron and add something to it. Seems like a safer way to go.
Right. So two issues come up here. The first is I am pushing Janssen to do a trial on monotherapy apalutamide, because I think that if there is validity to it, as Dr. O seems to think there is, then it would make an enormous difference to a company like Janssen if they could prove that monotherapy apalutamide is non-inferior, in other words, no worse than being on apalutamide plus the LHRH drug. So, because everybody and their brother would love to have testosterone in their body and get off the LHRH drug and just block the androgen receptors. Now, Zytiga is a different kettle of fish, because Zytiga doesn't block the androgen receptors. What Zytiga does is it stops the cancer from breaking down other substances in your body to create testosterone. So what happens is that there are other substances in your body that are testosterone based, like, for example, cholesterol. And the cancer gets so clever that when there's no testosterone around, it can go after those other substances and break them down and feed on testosterone that way. And that's what Zytiga addresses. So there's no point in having Zytiga without an LHRH drug. You might consider doing apalutamide without an LHRH drug, or even Xtandi without an LHRH drug. Because if these drugs were 100% effective and they can make androgen receptors, which are these little sort of molecules on the outside of a cancer cell that grab the food as it floats by, but if we were able to block them all off and stop them attracting any food, wouldn't matter how much testosterone's in your body, the cancer can't feed on it. But that's not the case for Zytiga.
Right.
Does that make sense to everybody?
Yes.
At the moment it does.
until next week or until tomorrow morning when you, what the hell did he say?
Rick, I got a Rick, what question? Did you say that Xtandi and apalutamide both block the receptors?
Yes. And darolutamide blocks the receptors.
And what?
Darolutamide, DAROLUTAMIDE. I forget the commercial name for darolutamide.
Oh, okay. I never heard of that one. What about bicalutamide does also, right? That's Casodex?
Yes. Bicalutamide does too, but it isn't a very effective drug.
Right. It's not as effective as Xtandi, right?
That's right, and it's not as effective as apalutamide either. And I thought darolutamide had a trade name already. Darolutamide was ODM 201 was what it originally started off as, and I thought it had a commercial name.
I don't think it's been approved yet, Rick, has it?
No, but I thought it had a commercial name, but maybe it doesn't. It definitely hasn't been approved, but no, it doesn't seem to have a commercial name yet. It's a Bayer drug, and it doesn't go through. It doesn't go through the brain barrier. So that's the drug that, again, we need Len, because Len actually participated in a session on that, in a focus group on darolutamide. We've talked about it a bunch of times. You can go back into the calls even over the last 4 to 6 weeks and search for darolutamide and you'll find information on them. So don't worry, it must have been whilst you were sleeping in the hospital, Paul.
What's that?
It must have been whilst you were having a nap in the hospital that we talked about.
Yeah, it's one of my problems these days. I doze off when I'm watching TV or something. I'll doze off for 15 minutes and then I'll wake up. I don't know what's going on.
It's healthy. Those cat naps are very healthy.
Yeah,
right, Mr. Curia?
I'm thinking it's more like a blackout,
I don't know.
That's one of the reasons we record these calls, Paul. Because then
Yeah,
you
I know.
go back and listen to it at a later date.
Oh, guys, we filled up the 2 hours. One thing I've noticed here is if we start talking about the technical stuff, everybody wants to get involved. If we start talking about the not so technical stuff, you all clam up like a bunch of patchogue clams.
Talk about things that aren't technical.
That's right. Hey, Jackson, did you notice that? Did you see how they all came back to life when we got back onto the technical stuff?
Well, the basic theory is that men don't cry and we don't have feelings and emotions, but
yeah,
we all know better. But you have to trust enough to open up and share. And that is, gentlemen, what we do on the Speaking Freely call, third Thursday every month. 8 p.m. Eastern Time, same channel.
There you
Be
go.
happy to have you join us.
There you go.
How was that for the commercial?
Nice segue, Rick. Nice segue.
It's a very good call, as Jake and others will tell you, and we have fun on it. All right, guys. That's it for today. The next call is next Monday. April Fool. April Fool. No, it'll be afternoon, so that we can't do any April Fool on afternoon. That's the rule. So we'll talk to you all then. Have a good rest of the week. Okay. Goodbye, everybody.
Good night, everybody.
Bye. Good night.
Ken just showed up. He got the wrong time.
Ken, you just showed up, Ken. Is that Ken Anderson? Good night. Is that Ken Anderson that just came in?
Yep, it is, Richard.
Hello, Mr. Anderson. We're just signing off. This was a Tuesday's a 3 o'clock call.
Oh, my mistake. Sorry for that.
That's okay. We had fun. We had about 10 or 11 people. Nobody wanted to talk about anything. So we talked a lot about neuroticism and the language of cancer. Nobody really wanted to participate. And then Paul Frieda brought up a couple of technical issues and everybody jumped in.
Well, I'll make sure to listen. I do have news about a rising PSA, though.
Oh dear, go on, tell us what's going on.
We've got 5-10 minutes.
What's that?
We've got time. Go.
We've got time for you. We always have time for you. You know that. Tell us what's up. Tell us what's happening, Ken.
Well, I'm not sure where it's coming from, of course, and I'm driving in my car, but I don't know why I had it on my calendar today for 5 o'clock. So I went in for my labs, and they came back. My last labs were like 40 days ago, and they came back 40 days ago at 0.78, 0.78, and this week they came back at 1.27.
Yeah.
At the moment, I'm on Casedex, so I know I'm going to switch to enzalutamide, and no doubt, I'm going to have a response. Just curious as to what kind and how long this response may last. Like I'm burning through these drugs fairly quickly.
Well, I mean, the bicalutamide, we were just talking about that for the last 10 minutes or so, or 15 minutes of this call. I mean, the bicalutamide is such an old drug.
No, I understand.
And there is the point at which it can turn around. I still don't understand why after all these years. But hopefully, you'll get a response out of either enzalutamide, or if it were me, I'd be asking for the apalutamide because I think it's a better drug. But that's just my own personal opinion. The other thing is, do you test your testosterone every time?
Yeah, my testosterone went from 1.2 to 2.6.
Uh-huh.
And I'm taking
1.6?
What's that, Jay?
Those are still very low levels.
Yeah, under 10 is very low.
So, yeah, I know it.
Testosterone or PSA?
So anyway, I think, I haven't talked to Paul yet. He's traveling this week. He doesn't return till the 28th. So, but I'm sure he was 50-50 either one. He said they both work very similar and the end results are fairly similar. I mean, I don't know. Not having to take prednisone is probably a plus in my head. I don't know if it really matters that much because I think I can handle it pretty well. I've been reading on how long the second line kind of works, and I must admit the timeline is not very long. So,
well, you haven't done Zytiga or Xtandi, correct?
No, I've not done either. I've done, Lupron, radiation, and chemo, and right. I did go in and see a radio oncologist, and his recommendation isn't to try to radiate because he said he can't really. He said he would recommend, and I know Jerry really well, so he said he'd recommend that I go to another guy and do I'd have to do an MRI and then do a biopsy and confirm that it's cancer and do something called needle-guided brachytherapy into the glands and inject radiation right spot on where the cancer is located. I mean, it was found in the PET scan, so it's possible that's where because quite honestly, my scans came back pretty clean other than that.
Right. So what he's talking about is high dose brachytherapy. And
Right.
these are, what they do is they put in, they insert rods, radioactive rods.
They don't do the rods at this place. They inject some radioactive material into your prostate, into the gland. They don't leave the seeds or the rods.
Okay. And then it's beyond my level of knowledge. But, you know, if it can be focused and done in that way, then it's definitely an alternative. But I want to come back to this second line anti-androgen. The Zytiga and the Xtandi work in very different ways. We just discussed that, so I'm not going to talk about it again, but you'll hear it at the end of the call. And as far as the Xtandi is concerned, I think that the apalutamide is a better anti-androgen than the enzalutamide. So Paul is saying, well, there's not a lot of difference between Zytiga and Xtandi. What I'm saying is, what about apalutamide as another alternative? That's another drug that is available.
So I'll ask him that in the email. I'm going to send him another email because he's going to get them all at once, I would imagine. He's probably reviewing them, traveling.
Yeah.
I don't know if he's taking a personal time off or going to one of these ASCO meetings. I have no idea.
You know, it may be that you're getting an adverse response to the enzalutamide. Jake, how much did when you started to get an adverse response to Casodex, how much did it go up, Jake?
I haven't had any adverse response to Casodex.
Well, I thought you said aren't you on Casodex right now or not?
Yes, I'm on Casodex right now, but it doesn't seem like it's working any longer.
Yeah, but that's what the adverse response is to Casodex. So Casodex can actually cause, Jake, talk to Ken a little bit about Casodex and what may happen with Casodex.
Okay. Ken, I took it by Casodex for about 1 year, and it worked. And then my PSA started going up. So then I tried a thing where I tried stopping it because there's a thing called anti-androgen withdrawal syndrome, which for some people, 30% or so, by stopping it, your PSA responds and goes down for a while. So that would probably be your next step. Once your PSA starts going up under the Casodex, try stopping it for a couple of months and see if your PSA responds. Mine did not. I was not one of the 30%. And then I started Xtandi, and I've been on Xtandi now for 2 years and 2 months, and it worked for a long time. It still works. We talked about that earlier too. You know, if I stopped it, my PSA and testosterone, my PSA would go through the roof. So it does still work. It's just not working as effectively as it once did. But I've gotten at least 2 years and 2 months out of it. Say again?
Are you still on Lupron at the moment?
Oh yeah, I've been on Lupron the whole time. Yes.
Yeah. Okay.
Yeah, we always leave that out, but it's kind of like an assumed thing. We should really preface that, and it's always including Lupron, no matter what we're taking. At least for most of us. So yeah, talk to your doctor about the anti-androgen withdrawal syndrome. Maybe it'll work for you for a month or two, 2 months, 3 months, 4 months. If it does, great. If it doesn't, then try the Xtandi. My PSA, once I started on the Xtandi, my PSA plummeted. It went down to 0.5, which is the lowest my PSA has ever been in my whole life.
Yeah.
It went down to 0.5, and you know, it's only been like in the last 6 months that it started to rise again. Meaning it's not as effective as it once was.
I mean, I just want to.
Xtandi, can you go from Xtandi to apalutamide after Xtandi fails?
Well, you can, but I just want to say, I mean, Jake says it's standing because that's what he was on, and apalutamide wasn't available. But for me, I would pick apalutamide over Xtandi today. So
Okay.
but
Well, apolutamide's not approved for metastatic, though, is it?
apalutamide is officially approved for non-metastatic castrate resistant, but
That's what I thought.
right, but it's accessible and it's available off label and certainly William O is prescribing it where there's metastatic disease. So
Is the side effect profile
what's that, Ken?
is the side effect profile very similar?
Better. It's supposedly has a better side effect profile than Xtandi.
Okay. Well,
And
as
it
you
does
know,
not cross the blood-brain barrier.
yeah, that's what I've read, but I've also heard that there's conflicts whether or not that's actually true. But I don't know. I'm going to ask Paul about it for sure, and my local med onc here. And if you think it's a better drug, I'll go for that if I can. I'm going to stop Casedex and see what happens. I'm not going to jump right on the bandwagon with whatever the next drug is. Maybe I can go a couple months without and
Right.
just do Lupron and see what happens to my PSA. Funny thing is, I don't feel any different. There's nothing like, I don't have any urinary problem. I did find a drug, and I finally got a hold of someone that could help with the neuropathy. There's some, and I started taking it, and it worked like right off the bat. It's like 3 yellow pills a day, or 2 in the morning and 1 at night, and neuropathy is completely gone.
What is it? What pill are you taking?
You know, I'm not at home. I'm just like 2 minutes from my house. If you'll give me a second, I'll tell you if we can stay online that long.
You could email me at pfrida@gmail.
Say that again?
Why don't send it to Rick, and then Rick can send it to us.
Okay. It was actually given to me by my general doctor, but it was told to me by, a lady that runs the front desk at my radial oncologist's office, which why she knows about it, who knows. But I can tell you right off the bat, I took it and it worked. I mean, I don't have any neuropathy in my feet at all.
Wow, that's great to hear.
Is it called Neurontin?
Yeah, I honestly don't know.
You don't remember?
I'll send it to you, Rick, via email. I'm going to put, I have an appointment scheduled for an SSID psych evaluation on the 10th. So I have to get all that stuff organized anyway, because she wants to know all the drugs I'm taking, and should be an interesting mental 2-hour mind fuck.
Right. And now, I don't know what's going on, but now Bill Franklin just joined us. Mr. Franklin.
I don't know what's going on either.
Yeah, this meeting was supposed to close about 20 minutes ago, 15 minutes ago.
What?
But Ken
What time
arrived
did it start?
late. 3 o'clock. It's Tuesday today.
3 o'clock.
Yeah. Your email said 5 today, right?
It did?
I thought it did too. I don't usually get on the Tuesday ones because it interferes with my karate class, but I had a function with my son at school, so I didn't go to karate tonight. So I came back. I thought I'd get on. I swore it said 5 o'clock.
Yeah, 6 p.m. Eastern.
It don't matter. You guys, that drug
That's all right.
The drug for neuropathy is gabapentin.
Gabapentin, yes.
Yeah, I've heard of that.
Gabapentin's been around. I've actually taken it, and I think it's also called Neurontin. I think gabapentin is the same as Neurontin.
Okay. I can tell you it worked.
Well, it's good. I didn't get relief off of it, but yes, it is a familiar drug.
Okay, Rick. So just in case, you and I have a meeting tomorrow night at 8 o'clock, right?
We do, and I'm
Okay.
looking, and let me just say, I'm looking at what I sent out, and it does say that the meeting starts at 3 o'clock Pacific, 6 o'clock Eastern.
Yeah, that's just me. That's just me being used to Mondays. So.
Right.
Oh, really? It was. I put it down on my calendar. I saw it and said I'm going to listen. I must have been. Again, I've been on Lupron for 2.5 years.
All right, I'll let you use that excuse.
Well, no, I'm actually looking at it. I'm actually looking at it.
Well, I'm not looking at it, but I'm
meeting
sure you got it right.
The meeting next Monday is at 8 o'clock, guys. 8 o'clock
Yeah,
Eastern.
Mondays are 8 o'clock. I know that. I usually go to the Mondays one.
All
And I've been,
right, guys.
yeah.
Well, look.
Yeah, well, don't let me keep you.
Well, thank you. But we do have a meeting tomorrow night, so I'll talk to you all tomorrow.
All right.
All right. But that's when I say talk to you all. We have a board meeting tomorrow night, gents.
Yeah.
That's what we're talking about. So I'll be talking to Bill Franklin tomorrow night. All right.
Good
There
night.
you go.
All right, everybody. Have a good night.
Night,
All right.
everybody.
Thanks, Rick.
Good night.
Night, guys.
Good night, everyone. Good night. Good night. Good night.